Mehdi's going to talk to us now about regenerative therapies for CLI, specifically the STOP PAD trial.
Thank you very much, Skyler. And we want to have a little bit of a paradigm shift. We're going to switch it a little bit. We talked about medical therapy, and Skyler did a fantastic job of highlighting some of the disparities which really are bothersome. I'm sorry, I clicked on the wrong talk. My bad. I apologize. I want to switch it up a little bit and focus a little bit on regenerative and biologic therapy with the mindset that we got to have a paradigm shift and go beyond amputation-free survival. We got to be thinking, how fast can we heal these wounds? And I think with that premise, I hope I can relate to you that we do need biologic therapy to try to help us advance the care of patients with CLI. Just to have some nomenclature and understanding of what we're talking about, what is biologic therapy and what are we trying to achieve? What is angiogenesis? What is vasculogenesis? What is arteriogenesis? So this review really does a fantastic job, and if you're interested in this field, I would highly recommend you review this from 2015. I haven't found anything nicer since then, so this is it. And basically, angiogenesis, which was first described by Dr. Folkman in 1971, it's related to formation of endothelial, sprouting of the endothelial cell, response to chronic ischemia, and the expression of VEGF, which leads to capillary formation. So we talk about VEGF and capillary formation. Now, on the other hand, vasculogenesis is a little bit different. So here the cells are originating from bone marrow. They require a homing mechanism. So things like VEGF and stromal drive factor 1, SDF1, hone those cells into the tissue where it's needed, and then they facilitate microvascular regeneration. So we have angiogenesis at the capillary level, and we have microvascular regeneration through the bone marrow and the paracrine effects and homing mechanism through vasculogenesis. And the review does a really fantastic job of going everything. Basically, to summarize the review for you, if you don't feel like reading it, there are many pathways that have been studied in the field of PAD and CLI. And these include gene therapy, as I have listed here, cell therapies with various tools, marker-selected mononuclear cells, and mesenchymal stromal cells. And collectively, unfortunately, despite all efforts, this was the conclusion of the review article, that it is disappointing that after extensive preclinical investigation and 2 decades of clinical trials, angiogenesis and cell therapy, we have no Food and Drug FDA-approved technology to help us treat these patients with CLI or PAD. So what's the problem? And why do we need cell-based therapy for these patients? So let's go back to a case. I think you always go from bench to bedside. So we're going to go back to the bedside and try to understand why this is needed. So this is a 65-year-old male, and I've shown this slide a lot in various meetings, but it really highlights what I'm going to tell you. End-stage renal disease, diabetes, all the risk factors that we know about these patients with CLI, has a little bit of a necrosis at the tip of the toe, dependent rubor, and avulsion of the nail bed. So patient comes, I do an ABI. ABI is 0.55. There is flattening of the waveform, so we take the patient to the lab. There is extensive disease, and I go in there and I spend 3 hours, and I take it to this. And I'm feeling very good about this. And usually I joke that I was going to send the picture to my mom back home so she can see her son is a very good plumber. But before I could send the images back to my mom, the patient came back. And I see these. Well, I learned from my vascular surgical colleagues, from my wound colleagues, that, wounds sometimes demarcate. You improve the perfusion, the area that has decent perfusion, and then there is the area that does not have the perfusion demarcates. Is it that? Did I embolize during the procedure? I just did angioplasty. I didn't use any atherectomy in this situation. Well, is it because I, destroyed some of the collaterals? I really don't know the mechanism. I mean, we can estimate what happened. But I said, you know what, let's go back to the hemodynamics. That should give me some information. So we went back to the hemodynamics. We had the pre, it was 0.55. Post is 1.04. I mean, we doubled the ABI. But then when we look at the TBI, remember it was 0.24 prior to the procedure. And now it's 0.16. And this is 2 weeks after the procedure, after I had done the procedure and the patient is coming back. So we really got interested in this. We were seeing a couple of patients like this. We said, you know what, let's go back to our database. So one of my fellows, Grand Hyatt, went back and pulled up all the patients with the TBI. And what we found was really amazing. I couldn't believe it, that the change in the TBI, the mean increase in TBI was from 0.18 to 0.29. These are called violent plots. So it was from 0.18 to 0.29. And I thought I was a great interventionalist. I do pedal arch. I do all these fancy things. You know, I mean, just, I couldn't believe it. So we then looked at this change and looked at the rates of revascularization. And we showed that, yes, the lack of change in the TBI actually predicts which patients undergo revascularization and significantly depicts that. So we came up with a cut point, and actually this work has been accepted to JACC intervention and should be coming out actually this week. We then reproduced this work. I don't have this slide, with one of my other fellows who is sitting in the corner of the room, Dr. Hamad, and that work also showed very similar results, and that work has also been accepted to CCI and should be coming out soon. But what's the point of this? The point of this is that there are multiple trials that are evaluating these patients with critical limb ischemia. There are still ongoing trials that are happening. But what is the problem? Why, after 2 decades, we haven't been able to get the answer? And in my mind, this is my view of it, is that there are for a number of reasons. One is that I think we are studying the wrong population. Most of the biologic studies have been done in claudicants or in patients that had no option, no revascularization option. We can improve macrovascular circulation, but as I've shown you, we cannot improve microvascular circulation. We need something else to help us with the microvascular circulation. And in claudication, in my mind, how can we improve symptoms in claudicants who have a macrovascular problem? They do have microvascular too, but their symptoms are macrovascular. That's why we stent them and they improve. And then we use the wrong endpoint. We have focused on endpoints such as ABI, which we know is inaccurate, walking distance, which we know is more related to macrovascular, or amputation-free survival, which nothing really can affect it. You need 30,000 patients to get an endpoint that is significant from an amputation-free survival. So we've got to change our mindset and start focusing on wounds and wound care. And this is the work of also Grand Hyatt, highlighting the importance of wound healing. Again, he showed that wound healing predicts major adverse limb events, and also showed in another paper that wound healing predicts readmission. So this is the direction we should be going. So this brings me to STF1, which is a homing mechanism. And this homing compound has been already shown that can have vessel growth and vasculogenic properties. And in animal models also, it's been shown that it has angiogenic and vasculogenic properties. And I'm not going to get into the details, but I want to bring you to the trial because of the lack of time. So we were able to build a team with the folks from Juventus, and we basically brought these slides that I really showed you to them and our experience. And we designed this trial to try to address some of these limitations. So we are taking patients with critical limb ischemia and tissue loss, so only ulcerations and gangrene, not Rutherford 4, only 5 and 6. After the patient consent, they undergo revascularization. Once they have done the revascularization procedure, they undergo hemodynamic testing. If their TBI is abnormal, if their microcirculation is abnormal, and we consider abnormal as less than 0.51, we then included them in a study. If the microvascular circulation was good, we didn't want them in a study. So we excluded those patients. If they met the TBI classification, we then randomized those patients to STF1 versus placebo. And then we followed with a primary endpoint of wound healing. And actually, this is the first time FDA has allowed wound healing as a primary endpoint in a phase 2 study. And John Runback actually has enrolled the most number of patients in this study, I think 18, if I'm not mistaken, or 17. So I'd be interested at some point during the discussion to get his take as to these TBI changes, because a lot of our operators felt that, you know, they would not have any patients, because after revascularization, TBI will improve, and that they wouldn't be able to include, and they've been surprised by how many of the patients actually do not have much of improvement in their TBI, even after extensive revascularization. So in conclusion, I think the future trials of gene or cell-based therapies should focus on appropriate patients, in my mind, with Rutherford 5 and 6, but hopefully more 5, because we have to catch the disease before it is more advanced. Endpoints should focus more on wound healing and rates of wound healing rather than amputation-free survival. We need thousands and thousands of patients if we want to impact amputation-free survival. And we need to focus on hemodynamic endpoints that go beyond ABI and even TBI, because we know those have significant limitation. What those are, I think we are still trying to figure out. TCPO2 is okay, but I think we need more advanced technologies. And we need to combine macrovascular with microvascular revascularization to be able to improve wound healing and care of these patients. Thank you.